Welcome to the Bioengineering Department Seminar Series. Thank you for coming. Today our speaker is Dr. Enrico Rejc. He is currently an assistant professor and the scientific director of the Neuromuscular, Metabolic, and Skeletal Research Core at the Kentucky Spinal Cord Research Center. He received his doctorate from exercise physiology from the University of Udine, Italy, and his presentation today is titled Recovery of Motor Function for Standing via Lumbosacral Spinal Cord Epidural Stimulation and Activity-Based Rehabilitation in Chronic Complete Paraplegics. Thank you.
Hey, good afternoon, and thank you for inviting me here today. So, as most of us know, after a chronic complete paralysis, the individual is unable to stand, walk, or move the lower limbs voluntarily. And this condition, dramatically affects the quality of life and also the health status of the affected individuals. But so staying from a movement perspective, so what this lesion, when there is this so-called clinically complete lesion, this so there is no fine motor control commands that are able to go through from the brain. But also what is interesting is that there are also some non-specific tonic inputs that don't reach the spinal circuitry. And we believe that these signals are kind of, switches that turn on the spinal circuitry that, in turn, those have an automaticity, meaning that they are able to control to a certain degree some basic movements like standing or walking and possibly postural control. So after spinal cord injury, these circuits are still intact but are silent because there is no more current, let's say, that turn them on. And this is an example of how these circuits are still able to function. And so this is a motor complete spinal cord injury that is placed on a treadmill with a body weight support, and there are two trainers that assist the movement of the lower limbs, as we will see later in the video. And so the spinal circuitry is able to generate this very nice locomotor pattern. And in some other mammals like cats, this spinal, the ability of the spinal circuitry to generate this motor output is even more important and can lead to the actual recovery of stand and step ability after weeks of task-specific training. So there are some animals that can actually recover locomotor function without any supraspinal connection, only by training. Unfortunately, other mammals like rats and humans, they don't show the same evidence for spinal cord plasticity. And so even if they are trained intensively, they don't recover the ability to stand or to step. And so this is an example of one of our participants. And so he will perform the translation from sitting to standing. As you can see from the EMG activity, there is some activity during the transition because of the sensory information driven to the spinal cord. But when he achieved the standing position, there is no more activity, and so the upright position is achieved only because of full assistance at the hips by a bungee, by an elastic cord, and at the knees by a trainer. So the first part of this was a brief introduction, and the first part of this talk is how epidural stimulation can help to promote motor function for standing in humans. So we know that back in the 80s and late 80s and 90s, there were some research groups that tried to stimulate the spinal cord via epidural stimulation, and with very high intensity, they were able to impose two distinct locomotor pattern, or let's say motor pattern, depending on the stimulation frequency. So with higher frequency, they were able to induce some rhythmic activity, while at lower frequencies, they were able to induce some tonic extension pattern. However, so this occurred with the patient in supine position and without any sensory information that somehow modulate this motor activity. And more importantly, this approach didn't lead to any improvement in motor function. So going back to 2009, 2010, our group tried to use the same or a similar approach. So stimulating the spinal cord, with the goal to enable this spinal circuitry that is smart somehow. So to enable it to generate motor patterns in response to the sensory information that are provided by skin receptors, by joint, and by tendon receptors. So using this sensory information as a feedback to drive the generation of motor pattern. And so these are the 4 recent participants that have been implanted at the beginning. And if you're familiar with the neurological scale of spinal cord injury, there are 2 who are graded as D. It means clinically motor complete, and 2 A's, meaning sensory and motor complete. And this is a figure that shows the stimulation unit that is placed in the abdominal cavity, and the electrode array that is placed over the T11L1 vertebrae. And this is a schematic that is somehow, that is not very precise, but what this tells us is that there are different parts of the array that should target different muscles. And briefly, the caudal portion of the array should target the more caudal or the more distal leg muscle, while the more proximal part of the array should influence the more proximal thigh muscles. So this is an image of our lab with different, there is a treadmill with body weight support, but mainly, the standing experiments were performed over ground here, and we record the EMG activity, the kinematics through our Vicon system, and also the ground reaction forces through our pressure map. And so this is one, to me, this is one of the most important slides of this presentation, because it shows two individuals during the sitting to standing transition. And you can see that for both of them, at the beginning, when they are seated, there is little or no muscle activity. And then, so without any change in the stimulation parameters, just the transition from sitting to standing drove this change in motor patterns that led to an actual ability to stand. So the point is that with appropriate stimulation parameters, and we are talking about this in a bit, so the sensory information related to this transition from sitting to standing drive the spinal circuitry to generate motor patterns sufficient for standing. And this is an example, about how these individuals, who again are clinically motor complete, they were told they were never be able to stand again. So how they are able to stand, so there is no assistance at the knees, no assistance at the hips, and they just use the upper limbs and the hands placed on a fixed bar to assist with balance. But other than that, they are able to bear full body weight and stand for minutes without any other assistance. And these are other two examples of standing outside of that comfort zone, so where the balance is a little bit more challenged. And in this video you can see that he's also able to catch and throw the ball while standing. Having a look at the motor pattern that allows this, so we can see that without stimulation, again, there is little or no muscle activation, and they are able to achieve the upright position only because of external assistance. So with stimulation, we have this overall continuous motor pattern, which can also be modulated if, in case of something happen, like there is a shift in body weight or flexion, for a joint flexion, for example. So it is not just imposed by the stimulation, but is continuously adjusted by the sensory information. So this is, I think, the first main point. And now what I think it is interesting from an engineering perspective is, this deals with the stimulation parameters. So here you can see that these four subjects have, different electrode configurations. So the black are cathodes, the active electrodes, gray are anodes, and white is non-active. And also you can see that there are different stimulation frequencies, so from 25 to 40, for example, and also stimulation intensity is substantially different, so can go from 0.6 volts to 9 volts. So briefly, how did we pick those stimulation parameters? So one important point, the link frequency and amplitude, as we previously saw, is that if you use an amplitude that is too high with higher frequencies, then you start driving those, intermittent rhythmic activity that are not good for standing. So, talking about amplitude and frequency, what we do, we try to kind of modulate them synergistically so that we achieve a continuous pattern with a relatively high frequency at a stimulation amplitude that doesn't actually drive this rhythmic activity. But probably the most difficult part is related to the selection of the electrodes that are active. So there are 16 electrodes that can be set in 3 different states, so active, non-active, cathodes, or anodes. And so far there are just guidelines that we have provided recently, but there are no fixed rule in how to select those. So what we know is that usually cathodes placed caudally and more caudal than anodes provide a more stable pattern with the distal muscles and mainly the plantar flexors more active than in this case, for example. I don't know if you are able to see, but so these 2 examples, only the caudal portion of the array is active, but in this case cathodes are lower than anodes, and there is a good pattern, while here they are flipped and there is some rhythmic activity, and actually some, a pattern that is absolutely not good for standing. Also, when these subjects try to stand at the beginning, we can have multiple issues. So for example, there could be an asymmetry between left and right leg. There could be an asymmetry between the amount of activity of proximals versus distal muscles. And so with trying to modulate which electrodes are active and how, that kind of help to fine-tuning the muscle activity of the whole lower limb. And this is just an example of how we try to, for example, to unbalance anodes and cathodes between the lateral columns of the array to try to increase in this case was to increase proximal muscles of the right lower limb. So we put an anode here and a cathode on the left, and we got something closer to what we wanted. But if we further unbalanced it, so putting 2 anodes here and 2 cathodes on the left, then we got a complete different motor output that was actually unuseful to promote standing. So far there are some guidelines that can help, but no fixed rules. And an additional problem is that even when we find some good stimulation parameters for one participant, if we, for example, if we use simulation parameters that were good for one Asia A participant, and we deliver them to this Asia B, so this is what we happen. So a lot of flexion, the need of external assistance to keep him upright. So the point is that even if we kind of optimize these parameters, these are not good for everyone, but rather for just that one individual. And this can be due to different reasons. Probably these are 3 of them. One is the actual individual differences in spinal cord anatomy, and more importantly, the position of the electrode array with respect to actual spinal cord. And also because after injury, these lumbosacral circuits undergo plasticity, and this can be different, given the motor experience these patients had, or because of the type of the lesion. So these are some of the challenges that we face. So this was the first part that was more related to the actual stimulation technique. And so this second part is more related to the training effect, to the activity-based effect. And so what our 4 subjects did, so they underwent 80 sessions of locomotor training before the implant, just to make sure that the usual way to rehab them didn't bring any significant improvement. And that was the case. So after that, they were implanted, and they underwent 80 sessions of stent training first with stimulation, and this was followed by 80 sessions of step training. So briefly, stent training, 5 sessions per week, 1 hour of standing per session, and the original goal was to stand for an hour with the least amount of assistance that was provided for knee extension and for hip extension. And so this is an example of step training. It was also 1 hour per day, 5 days a week. The goal again was to try to step for an hour. Obviously in this case was assisted stepping, but trying to, again, to step with assistance, but with the lowest amount of assistance. So this is an overview of some behavioral characteristics throughout the 80 sessions of step training for the 4 subjects. And what I think is interesting, for example, these green lines, so this stands for the amount of time that they were able to stand without knee assistance. And you can see that this ability and the time cost of this ability is really different among these 4 individuals. For example, this one was, since the first week, it was able to stand for about 40 to 45 minutes without knee assistance, while this one, achieved this ability only after 30 stent training sessions. And what it is interesting as well is that these little black vertical lines, so they tell us when there was a change in the electrode configuration. So like in this case, right after a change in electrode configuration, this subject achieved the ability to stand without knee assistance. So in this case, it was essential for him to change electrode configuration. While in this case, for example, so he was still able to stand for a good amount of time without knee assistance, and this ability improved over time. However, it jumped up when there was an improvement in electrode configuration. So this to say that training and stimulation parameters, they really are interrelated. And so in order to investigate the pure training effect, so we did before training and after stand training, we have them, standing with the same stimulation parameters that were used before stand training. So same parameters pre and post stand training. And in this way we can see, how stand training only affects standing ability. And we can see that, 3 out of 4 subjects somehow improved after stand training, while 1 only didn't improve. However, if after stand training they were allowed to use the new improved stimulation parameter, their ability jumped up. So this is after stand training with improved stimulation parameters. So again, the relative effect of stimulation and training. What we didn't really expect, however, is that after step training, even if they use the same good parameters for standing, standing ability actually impaired. So even if they kept training but stepping rather than standing, so the standing ability impaired. And so this is a brief overview of the NG pattern before and after stand training with the same stimulation parameters. And this is what it means behaviorally. There is a lot of flexion and the need of assistance before training, and a very quiet standing without external assistance after training. So this is only, training effect, because the stimulation parameters are the same. So similarly, before and after step training, and we can see that in 2 individuals mainly, we have a completely different motor output after step training as opposed to before step training, even if the stimulation parameters are the same. And this coincided with an impaired ability to stand. And when we go back to the literature and animal studies, there were several cats and also rat studies that showed something similar. So that cats that were complete spinal cats that were trained to stand, they were unable to step actually, because the spinal cord learned that specific motor task, namely standing. However, so after several months of step training, these same cats were able to, actually stepping. So from this data, we can state that also the human spinal cord is able to learn to perform a motor task. However, this motor learning process seems to be task specific. And so one way to look neurophysiologically at this spinal cord plasticity is, for example, to deliver stimulation at a very low frequency. And what we have done in this case, so we have compared the amplitude of these evoked responses in sitting, so where the subject is relaxed, and no motor tasks are performed. So comparing the sitting to standing responses, again with the same stimulation parameters. And what we get is that the gain in the amplitude response due to the change in body position, since the parameters are the same, that has to be driven by the sensory information and by the sensory motor pathways involved in that change in body position. So we can see that for, primarily the extensor muscles that are this, and for all the muscles that we have analyzed, if we pull them together, we have that stand training actually increase the gain in this amplitude of the evoked potentials if we compare standing and sitting. So we can tell that there is a strengthening of these sensory motor pathways involved in that motor task. But if we repeat this experiment after step training, we can see that in these two subjects that are the ones that show the better standing ability, so this sit to stand ratio went back to the pre-training values. And this is a sign of, task-specific plasticity. And it is also interesting that this third subject that didn't show a very good standing ability had a completely different recordings from this point of view. So it looks like if you get the right spinal cord plasticity, that somehow can coincide with a better standing ability. And so lastly, we asked the question whether stand and step training induced plasticity studied in a non-motor task performance can somehow tell us something. So what we did, we record the muscle activation threshold in supine position. And so to make the long story short, we saw that during a relaxed condition, we actually saw the greater spinal cord plasticity after step training, and only in two individuals that, they were the one that stood worse than all the others, and the one that showed actually the best standing ability. So what this tells us is that if we investigate spinal cord plasticity during a non-task specific condition, we can see something that is not related to the actual performance. And lastly, when we compare sitting and standing EMG activity before any training, after stand training, and after step training, but without any stimulation, we can see that in spite of the intense motor training that they underwent with epidural stimulation, if they don't get the actual spinal stimulation, so EMG activity is not modulated, and they are not able to achieve standing, and the related motor output is not even improved. So training with epidural stimulation improved motor function only if epidural stimulation is provided. So without epidural stimulation, we don't see any improvement in motor function. So just in conclusion, what we have seen so far is that individual-specific stimulation parameters and task-specific training can promote the recovery of full weight-bearing standing with only a slight assistance for balance in chronic complete paraplegics. And also, what is important to note is that standing ability can actually impair after step training. So far what we are currently working on is a different training protocol to see if that can improve both standing and stepping, and also with some companies, we are trying to improve the stimulation technology so that we can have a greater capability of changing, for example, electrodes, or having a more detailed abilities to select where to stimulate the spine. And so lastly, just flash on other measurements that are more oriented toward muscle physiology, but also they are more, health related. That we can actually assess in this lab, a lot more focused on muscle function from strength point of view and from the oxidative capacity point of view. We will briefly be able to assess resting metabolic rate. And also with Dr. Elbaz, we are developing an algorithm to actually analyze the different tissues of a muscle MRI, so fat, natural muscle. And also we have capability of muscle and cardiac ultrasound, and also DEXA to measure mineral bone density. So this is a brief overview of what we can also perform, that we are certainly open for collaboration. And with this, I'd like to thank the funding agencies, the first 4 subjects that underwent the study, and Dr. Harkema, Dr. Angeli, and all the research staff that collaborated. They are actually collaborating to these research projects, and you for your attention.